This is actually, pretty interesting in the sense that again, things can get pretty complex. This is a basic angiography talk, and we'll start a little bit with vascular access and some of the options. And I think the importance of this is not just for the case that you're doing at that point, and it may be something actually quite simple, but for those of you who are at programs where you do a lot of high-end vascular aneurysms and things like that, certainly access, it becomes critically important because we're doing a lot of aneurysms, the so-called pre-close technique or percutaneous aneurysms. And so it's just basic objectives of what we'll talk about here today. So for access, obviously the common femoral artery is our most used artery for access. Typically try to access it in its sort of middle third, right over the femoral head. It gives you a good place to compress. It's a nice, safe place if you can't use a closure device or you need to just use manual compression. Other options. So those of you, anybody done a brachial puncture? So residents or fellows, or obviously we had some attendings here. I'm sure you guys have done that, but brachial artery access. So brachial artery is that's tricky, and I think one of the main things we think about with brachial artery access is where in the brachial artery. I think many of us now, certainly me included, I really favor a much more distal brachial artery access, typically at the level of the antecubital fossa. It's a little bit easier to compress in that location, and the brachial artery is notoriously, it can be quite tortuous. Older people sometimes have kind of flabby arms. There's really not a good way to compress it against the shaft of the humerus. And so I think that a lot of times the brachial artery, although we use it not that commonly, I think is probably a distal location is better. Antegrade access, most of our access, for example, a common femoral is retrograde. Antegrade, you do it frequently, but that's really, it's in the setting of intervention, and most often that's in the setting of something like a popliteal aneurysm repair or limb salvage, tibial or pedal intervention, something like that. Radial, I don't do those. Cardiologists, of course, are really shifting a lot more towards radial artery access. For IRs, I'm not sure if it's that big a deal. I'll just say that for so much of what we do, even visceral artery interventions, you think, we've got a downward going SMA related to the axis of the aorta. You think it might be easier to do from the arm than coming from the groin, and it may be, but it's never quite as easy as it seems. It's a lot farther distance. You're working in a little bit of an awkward location, so femoral artery is clearly the preferred. Anybody done a true kind of old school axillary artery puncture, arm up like this and right over the humeral head? I think that's probably for historical purposes only. I don't think anybody does this anymore.
No, we still do.
You still do axillary artery punctures?
It depends on the length that you have to travel. It's a very compressible structure against the femoral head. It's very superficial. It is hard to get to. Heavier people doesn't really work well. It's one thing to consider, but it's not that common.
Yeah, not common, and I think it'd be pretty dangerous. There's a few people wandering around out there with dead arms from axillary artery punctures from compression of the nerve sheath. All right, so routine for femoral artery access. How many people use fluoro to mark before you puncture? Probably almost everybody. Do you use fluoro to mark even if you're going to use ultrasound?